Hello everyone, welcome. This is our first case study circle and I am so excited to have you all join me. I am Sujata Martin. Many of you may know me as a pelvic health therapist and educator based in Tampa, Florida. And our specialty here at the Integrative Somatic Healing Institute is combining time-tested wisdom from Eastern medicine along with evidence-based practice in Western medicine. So today we are going to look at a case study presentation. This is going to be for a client who was post dates, and I know sometimes that definition varies depending on the maternity care provider, but this specific client was 40 weeks and 5 days, coming up on that 41-week mark where her OBGYNs were getting a little concerned and there were a few other complicating factors. I'm going to take a peek here on the logistic end of things and make sure everything is lined up for a beautiful viewing experience. We are going to be online for 30 minutes, so make sure you have a drink of water, a snack, maybe a notepad to make some quick notes, because I assure you, you are going to take away information today that you can start applying with your clients starting now. That is the goal of these case study meetups. So that being said, let me just take a quick peek and I will try and make this as interactive as possible. We will have some Q&As. We invite questions from you, our audience, whether you're watching live here or you're watching the recording in our Facebook group, the Integrative Somatic Healing Institute Pro Circle, or on YouTube. Please send us questions on YouTube or Facebook. We love having our learners, our healing community engaged, because we want to reach you with information that is pertinent to your practice, to your clients, to help them get to their goals faster, quicker, and safer, and being pain-free. So to paint the picture, this client is a pregnant mom who is 40 weeks and 5 days. This is her second baby. Her first baby was born vaginally in a hospital without any medications, without needing an induction. So this time around with baby number 2, mom is a little surprised that she is at that 41-week mark and baby is not here yet. The other complicating factor is that she was 33 years old with her first baby, and now she is 35 and a couple months old. So of course, with maternity care in the US, you cross that magical threshold of 35 years and now you are geriatric, right? So this pregnant mom who was in otherwise great health, so she has no concurrent medical diagnoses, nothing is going on. She is tracking well, baby is tracking well throughout the pregnancy into the 40th week. And still she is being labeled as a geriatric pregnancy, as a high-risk pregnancy. Towards the end of her pregnancy, especially from week 40 and week 39 and into week 40, this client had consultations with a maternal fetal medicine provider. So this is almost, it is a OBGYN, and this is a physician who has a higher level training than an OBGYN, who is skilled to make decisions regarding high-risk pregnancies, managing moms and babies who may be fragile. Now, this client, even though she was 35 weeks and 35 years old and a few months, she was termed high risk just based on her age. She had no other high risk factors. Her blood sugar was fabulous, GBS negative, diabetes was great, no other history, no other blood work concerns, and same with baby. But in week 40 and in week 39 and week 40, she began receiving 3 times a week scans, non-stress tests. A non-stress test is done typically at a hospital. There are some outpatient facilities that may do it as well, but typically in a medical care facility where further care can be provided if needed, and the baby is checked for any distress. Something called a biophysical profile was done, a BPP, to make sure the placenta was functioning well, blood flow in those umbilical cord vessels that go from the placenta to the baby were functioning well, everything was good, baby was getting enough circulation. That is what was checked, and this mama was tracking well on that end too. So when she presented to our office at 40 weeks and 5 weeks gestation, that's what she came with, being termed high risk because of her age, which was 35 years and 4 months. She was also called high risk because of trying to have as natural birth as possible. She wanted to try and have an unmedicated labor, not have induction, but she was being counseled by a maternal fetal medicine provider, and a lot of verbiage was used that honestly was creating more harm than good. Medically, everything was fine. This mom had not received pelvic floor therapy with her first pregnancy or postpartum, and had not received any pelvic floor care for this pregnancy prior to this point at 40 weeks and 5 days. So this is honestly a uncommon situation. Most of our pregnant clients, us pelvic floor therapy providers, we follow for a few sessions, and then we have a fuller picture of them medically, physically, emotionally, spiritually, energetically, right? We get a fuller picture of them, and we can address them at all those levels within our skill set. So with this client, I did not have the benefit of that. This was my first time meeting this mom, and we wanted to do as much as possible. This was Thursday, and she had a induction scheduled for Saturday, which would be 41 weeks, because her medical team said that 41 weeks, the health of the placenta would start degrading. It would put a lot of risk on baby and a successful delivery. So they wanted her to be induced. So that is what we were working with. So when this mom came, her primary concern was that she was very, very scared that this, and I should take that back. Her primary concern was that she wanted to have as easy a birth as possible without any medical intervention, because she had that birth experience with her previous baby. She had a non-medicated birth, and she was hoping for that with the second child as well. Now, this baby on exam from the physicians, they said that she did have a case of polyhydramnios, so a little extra amniotic fluid. They did not tell her anything beyond that. So to me, upon assessment, what stood out was we first did a full body assessment, did a medical history, did a postural scan, assessed her movement in standing, in quadruped, in a standing hip hinge, over a space in our office, in our clinic. And what was found was that this mom had wonderful pelvic mobility. If anything, the only thing that was going on was a little extra hyperactivity or increased tone in her paraspinal muscles. So the muscles that go, especially in her lower back. So if this is the pelvis and this is the L4, L5, lower lumbar spine, the muscles that go on both sides of our lumbar spine from T12, so last thoracic to L5, were a little overactive, working a little hard. And this made total sense with her diagnosis of polyhydramnios, which is excess amniotic fluid, because her belly was much larger than normal. So her back muscles were working a little overtime. So from a pelvic floor therapy perspective, what can we do? This mom had good pelvic mobility, no restrictions, no significant restrictions around her pubic bone, along her sacrum. I did an internal pelvic exam. She had minimal restrictions. Again, this mom was a rock star. She was walking, she was doing her stretches, she had a sedentary job, but she would use a birthing ball and do her exercises, keep pelvic mobility going through the day. So even on an internal exam, there was not much tone. So as a pelvic floor therapist, then I'm problem solving in my mind, right? So this mom said that she feels like she has a blockage or some pelvic muscle tension, but upon exam, everything moves well. So from a physical standpoint, there was nothing tight or tense. And that's where we use our clinical reasoning, and we use the clinical reasoning that we learn in the integrative pelvic care model. In the integrative pelvic care model, or IPC, for pregnancy, which is our flagship course here at the Integrative Somatic Healing Institute, we understand that birth is not just a physical process. So yes, everything that happens in here, in the pelvis, in the pelvic floor, inside the pelvis is very, very important for pregnancy, for ease in labor and birthing. But what is equally important, and honestly almost a little bit more important in my professional experience, is what is happening in the mind, meaning what thought patterns have been settled into this person's unconscious, subconscious and conscious mind, as well as what is going on in her heart. What are her feelings about this event? Not just her thoughts, not just the rational thoughts. What are her emotions? What are her feelings? So I had this conversation with mom, is that I assessed your pelvis and everything looks good. You move really, really well. Your hips have great mobility. Internal pelvic floor looks fabulous. But I think there is something else going on. And the only way to address this, and we go over these skills in our Birthing in Power course. There'll be some more details coming up both in this video, in this group, as well as in our emails. So if you are not subscribed for our emails, please subscribe now. You don't want to miss out, because we get so many questions from pelvic OTs, pelvic PTs on, oh, how do I address XYZ in my pregnant mom? I think this is going on. Because yes, a lot of courses, a lot of educators out there teach you how to manage the aches and pains of pregnancy, but no one is teaching you how to address pregnancy and birth from a biopsychosocial perspective. And that is so important. So coming back to the biopsychosocial, right? We figured the bio, the physical structure of both the external and the internal pelvis was fine. So let's look at the psychosocial. Socially, what was happening? So socially, mom had a great supportive partner. Dad was very on board, but she had some fears, some things that she hadn't fully communicated with him. So let's go into the psycho, right? What is going on cognitively, and I add emotionally to that as well. So I had that conversation with mom that, hey, I assessed you, things look wonderful physically. Are you carrying any fears, any difficult emotions within you? And that's when mom was just a minute of silence and a realization that, wow, yes, I am. And when I gently probe more, she says, yes, I have been seeing the maternal fetal medicine specialist 3 times a week, or once a week, and getting scans 3 times a week for the last 2 weeks. And every provider who sees me tells me that I'm being irresponsible and baby could die. Baby could die if I refuse an induction. Baby could die if this birth doesn't happen now, because I am of advanced maternal age. That's right. Our medical system right now classifies women who are over 35 years, no matter their health status, as advanced maternal age. And they are concerned that something will happen to baby. She also mentioned that with her previous pregnancy and birth, where baby was born unmedicated, however, there was a little distress during birth, including meconium in the amniotic fluid during delivery. Baby was completely fine. Baby did not need any resuscitation, anything of that nature. She was fine. Delivery was smooth. However, she had that deep-rooted belief that, or deep-rooted fear, that because there was meconium, baby poop in the amniotic fluid with baby 1, same thing could happen with baby 2. And that the doctors were already telling her that she's older, her placenta is degrading, and that something could happen to baby. So we address that. So we address that fear through the process we go over in our Birthing in Power course. Right? There is this little beautiful table. For those of you who have taken the course, you know what I'm talking about. We put that fear down there and we ask them about best case scenario, right? But what is the best thing that could happen? So having that conversation that you are under care of providers who are capable of assisting you in case something serious happens medically. We helped her find tools that she could use if there were consequences that weren't entirely in her control. More so, we asked her husband, like, oh, has client M mentioned this to you? And the husband was just like, we haven't really talked about this. So mom also, as she was preparing emotionally for birth, she almost didn't want to bring that fear up into conscious awareness. It was something she had filed away in her subconscious and unconscious brain. She didn't want to bring it up into conscious awareness, but that bringing into conscious awareness actually helped us find solutions. It led to a conversation with her partner on how to address that fear. It led to me counseling the patient that this birth is so different from her first birth. She has learned strategies to assist with labor and delivery. She knows her body better this time. Her body is better prepared. We had gone over some very basic practice pushing. So we knew that this birth is going to be different from her first birth. Also, what besides addressing the biopsychosocial component of the situation, addressing her fears, reassuring her that just because she's over that magical number of 35 years, suddenly she's not unhealthy. Reassuring her that the medical team is monitoring her health, doing all those scans, and those scans had assured her you are fine because there was not a single abnormal finding on those tests. And I wish someone on that OBGYN team, someone on the MFM physician side had counseled this patient that yes, by rule, by guidelines, you are considered advanced maternal age. That needs to change. That's a whole other conversation. But even though you're advanced maternal age, your placenta is healthy. Your cord is getting blood to baby fine. Your parameters are good and baby's parameters are good. You both are healthy. This poor client, this sweet client, I should not say poor because she wasn't a victim. She was so strong. She knew to advocate for herself. So this sweet client, even though everything was good and she was healthy, was being fed a lot of fear by the medical team. So we had to address that fear and we coached her through a release breath. So this is a breath we practice a lot in our coursework in the Integrative Somatic Healing Institute. We will soon be releasing a free mini course on birthing in power. So all of this content that we are going over just now, it is covered in the mini course. And of course, the mini course is like a little taster, right? Like a little aperitif for the actual course, which is going to be almost 6+ hours of specific biopsychosocial education for you, the perinatal pelvic health provider, to address pregnancies more holistically, more fully, and to prepare your clients for this kind of outcome. We did that breath work, we did the pranayam, the exhales, where we focus on releasing energy, releasing fears. As we talked about her fear, that the MFM mentioned, your baby will die or something bad will happen, we learned to let go of tension in our breath, in our body, and just practicing that for a couple times and then bringing her back. And how does that make you feel now? And just the energy in mom shifted from being tearful and almost a little tearful and fearful, just like, I feel okay, I think I can do this. Just the change in the client with doing that breath work, with doing the pranayam, which lets go of energy, which we call fear release in our coursework. Just that fear release around those specific fears was so empowering to this mom. So again, if you are not doing this already, please do a targeted fear release, whether that is feelings of fear, like hypothetical fears, or very like physical tissue related fears, like a lot of mothers will have fears of tearing, fears of something happening, right? We address those as we release our breath, as we release energy. It's an extremely powerful technique to help our pregnant clients find strength, find stability, find power in themselves during birthing and during pregnancy too. So that was a big part of our intervention, the fear release. Of course, we did a lot of physical hands-on manipulations to again make sure everything is as best as it could be, but this mom did not need much. And again, in the Birthing in Power course, which is the Integrative Pelvic Care for Pregnancy course, we go over how to mobilize the sacrum, how to mobilize the pubic bone, how to release these ligaments, the sacrotuberous ligaments on both sides, both externally and internally. And so whether you are a chiropractor, a nurse practitioner, a midwife, a pelvic floor therapist, within your scope of practice, you can use these techniques for your clients to be better prepared from that biopsychosocial approach. So the whole course will be releasing soon. We have a Memorial Day launch date, and there will be a free mini course being announced. So please don't miss out. You'll have to join our email updates to get that info. And final piece we wanted to address, this is a little advanced, and as you add to your skill set with these integrative pelvic care courses, you will be able to do work along these lines. The polyhydroamnios. So that's the other thing about our medical care system in the United States. We receive labels, but rarely we get information on how to address that. So it was very obvious to me as a seasoned practitioner in pelvic care that because of her excess amniotic fluid, like this baby, like there was so much amniotic fluid in the uterus. So again, I want you to visualize, if this is the pelvis, the uterus is going from in the pelvis to it is becoming abdominal, right? And the baby is head down, well positioned for the most part inside the pelvis. But the thing was, the baby, because there was so much fluid in the uterus, was floating up high. Labor starts because the baby's head starts putting pressure on the cervix, which is the opening of the uterus. So the pressure on the cervix is what helps with those mechanical changes happening. There is of course a hormonal crosstalk between mom and baby. Baby's lungs start maturing, and there is that release of, that starts the cycle of small level contractions. But the mechanical pressure from baby's head on the cervix is very, very essential in getting the process of cervical dilation going. So again, because of polyhydroamnios or excess amniotic fluid, this baby was floating higher, so there wasn't a whole lot of pressure on the cervix causing cervical change. And I educated the mother on that. So again, this is something I always say, as experienced practitioners, a lot of us pick up skills and knowledge that may be out of our traditional skill set. So always educating with that statement, with that specification, that this is something your doctor may discuss with you, but the excess amniotic fluid may be interfering with baby engaging at the cervix and dilating. And I told her that your doctors will likely recommend, or I told her that once your waters break and baby is able to come down onto the cervix, labor will move quickly, because this mom had fabulous alignment in her pelvis, really fabulous, externally, internally, and we had done the fear release work. And then she says, oh yes, a doctor did suggest that we should break your waters to get labor going. And I told her, like, that makes sense to me. I'm not, please follow your medical team's directions, please follow their recommendations, but it makes complete sense to me that I can visualize labor going quickly once this baby is able to properly engage on the cervix, once there isn't as much amniotic fluid in the uterus. So to that end, what can we as integrative care practitioners do for helping a mom with increased amniotic fluid? So please recognize that Birthing in Power is our foundational course for pregnancy. We will in the future release more advanced concepts, and addressing polyhydroamnios will be one of them. in our in-person training. We are announcing the date soon. It's gonna be July 4th weekend. We are gonna shoot for that. So we will be going over hands-on skills for helping transverse and breech babies get in better positions. So please mark your calendars for July 4th weekend. This course will be in the Tampa Bay area in Florida. So, and keep an eye on the email for more details. We will go over the polyhydramnios treatment from our perspective in there too. But in a gist, when there is any fluid imbalance, so increased amniotic fluid at the end of the day is a imbalance in that fluid, the fluid levels, right? So from an Eastern medicine perspective, any kind of fluid overload or even decreased fluid, it's a little different. That comes to mostly nutrition, nourishment, rest. Increased fluid is almost always congestion of the liver and the kidneys. So anything that we as practitioners can do to improve liver hepatic mobilization, and there is science behind that. So of course there is science behind it from a Eastern medicine perspective, but from the Western medicine perspective, the inferior vena cava passes through the liver. If there is any hypomobility, any restriction in mobility of the liver, it can reduce that backflow of liquid up from the lower body. So when we have varicose veins in the vulva, when we have increased pelvic pressure in postpartum prolapse, we always should look at the liver. We always should consider fluid congestion, lymphatic congestion in the lower abdomen and pelvis. So that is also what we did do with this mom. And again, when someone has fluid imbalances, we ask them to create balance or to facilitate balance by hydrating well, and not just with water but with electrolytes. So this is again a little pro tip for you. If your client has puffy ankles and puffy wrists, or they have polyhydramnios, like too much amniotic fluid, they want to drink, or less, you want to drink lots of water, right? Less amniotic fluid is a little different. With more amniotic fluid, you definitely want to mobilize liver, kidneys, get them good electrolytes, and foods that support the liver will help. So acupuncture is wonderful also, and that is how we address this patient. She was post dates, even though technically full term is still 42 weeks. There was a lot of fear this client had, saying that she was post her due date, right? This client was termed advanced maternal age for turning 35, even though she was perfectly healthy, and she had a baby who was not engaging due to excess amniotic fluid. So from that integrative pelvic care perspective, we address that by educating her on what is normal, what is not, on doing a fear release based on the fears she had acquired from her medical team and their statements. She had supportive providers, but there were a couple of providers who were not supportive. So addressing those fears that had settled in, causing some muscle tension in her pelvis, and honestly more internal tension and fear. We addressed that through the fear release technique, and we educated her on increasing electrolyte intake and did some mobilizations to her liver area to help with the fluid balance. So that was our management for this patient who was post dates through the integrative pelvic care model. I would love to field any questions you may have. I am so happy that you were able to join me here today, and so excited for you to learn and grow this field of integrative pelvic care, where we can support our clients not just physically, but emotionally, energetically, cognitively, all of that. Thank you so much for joining me, and have a wonderful day ahead.